So somebody who has coronary disease does have a higher risk of having peripheral arterial disease, carotid disease, and stroke. But at the same time, someone who is diagnosed with early peripheral arterial disease also has a higher risk of having a heart attack and stroke as well. So now, knowing that it's the same disease, we have now identified that all the issues that are encompassed in this one disease process, and now we can treat them effectively, both with medications, with surgeries, with interventional procedures as we need to.
John, how now that Nick has talked about the spectrum coming from below to above, like PAD to coronary artery disease, being in the interventional world for as long as you have been, what is your perception of going down? What is our role, as well as what is the whole patient burden when you have a patient with advanced, or they come in with coronary problems, we do stents or we do different things to treat them. How did you visualize, how did you view this and go down the spectrum of this PAD problem?
Right, well, where I trained, PAD really was just sort of beginning to be part of a cardiologist problem. So during my training, the focus really was just on the coronary piece of it. But once you get into practice and you realize, as Nick has pointed out, and you live the experience of having patients come in with heart attacks only to have a stroke 6 weeks later, you begin to understand. Initially, workup in the coronary world was just that. We would do a stress test on the heart. We would, sometimes do a heart catheterization specifically to look at those blockages if the tests were abnormal. Now, our practice really has shifted. It's more about evaluating the entire vascular tree. So we now are much more aggressive at looking at carotid arteries, looking at the leg arteries, doing very simple screening. One of the things Nick and I are building into the practice is screening using ABIs, which is a very simple test with blood pressure cuffs. But because Ms. Smith, for a lack of a better name, comes into my office and she complains of some chest pressure, and I identify her as having coronary disease, well, now I know I need to be more aggressive looking for the other problems in the vascular bed. So we start looking at the screening tests. Okay, do we screen for the legs? Do we screen for the carotid arteries? And yes, we do. And by being aggressive, hopefully we identify these problems before permanent damage.
Yeah, that's absolutely well put, because the whole burden, as the statistics and these things point out, the data points out that the understanding that if there is person has a PAD, there is a high degree of coexistence of coronary artery disease, and most of the people may end up dying because of heart problems and maybe a stroke as opposed to a leg problem. Of course, if they have a leg amputation, or they're unable to exercise or have different problems, that's not a great thing either.
That's right.
But I think most likely their major risk factors are dying from a heart attack and stroke, which puts a great deal of burden on us here in identifying that all these problems coexist. And
absolutely.
It looks like we are getting one more call. We'll take this and move on with our discussion. It's Felicia from where? Mamu, line 1 again. Felicia, go ahead, dear. You're on line.
Yes, I was calling to ask a question about arthritis in the legs.
Okay, go ahead.
What can I do about that?
Well, is your question whether arthritis can be similar to peripheral arterial disease, or are you saying that you just have arthritis in your hips or knees or something of that nature?
I have it in my whole leg, both my legs.
Okay. Well, we'll try to answer it in the best way possible here. Well, I guess she has already, looks like she already knows that she has arthritis. Hopefully she has had some workup like x-rays or MRI or something. But based on her age, I guess we can stratify her.
Well, she may certainly have arthritis, and of course standard treatments for arthritis being non-steroidal medications, so things like Motrin and Naproxen and those sorts of medications, a good evaluation of the bone structure to see if there's been a complete degeneration. Sometimes it even requires surgery depending on the decompensation of the joints. But here's an interesting anecdote I'd like to share specifically with this lady, and that is my father, who for many years was identified as having arthritis in his hip. And his arthritis kept him from being able to play a round of golf the way that he wanted to play golf, and actually got to the point where he could barely walk at all. It turns out that actually his arthritis was peripheral vascular disease. He had an evaluation, by a cardiologist who identified poor blood flow to his extremities, and then once he was evaluated, he underwent treatment for his peripheral vascular disease, and he's now able to swing the golf club and walk again. And all of a sudden, miraculously, his arthritis has gone away.
Incredible, the story that you just said, which has pertinence and relevance to this lady's story. So it means that anybody who's of a certain age and has the risk factors, which we'll probably talk about when we get a chance here in a moment here, with the right kind of risk factors of a certain age, all these syndromes of arthritis, peripheral arterial disease, and neuropathy, or this nerve compression things coming from the back, all of them can overlap so much with each other that there is an easy chance of confusing and putting this off, and which happens repeatedly in all of our practices. Right. In fact, I had a gentleman who's not that old, maybe no more than in his mid-50s, has been treated for years for back pain and arthritis. In fact, has had back surgeries and has a complete blockage of his right common iliac artery all the way to the common femoral. And he was barely able to walk from here to the door without really stopping. And he was 55 years old.
That's right.
So this happens very often. So that's one of the reasons why we chose that kind of a quirky little title saying that is all arthritis like old age or joint pains or something, is all leg pains that. But really, I think we see that repeatedly. And tell me, in your practice, when they come in, what are the basics that make you suspicious? If they come in with a cold leg, we know they have problems. But outside of that, when do you start getting concerned? How would you quickly take your patient and try to kind of pigeonhole them whether they have PVD or not?
Well, classically, the history is some kind of leg discomfort when they walk. That's, claudication it's called. And basically, it's they have discomfort either in their calves or thighs or sometimes even their buttocks, depending on how high the blockage is. And it's usually at a predictable level of walking every time. And if those patients stop and stand still, usually the pain is relieved. The reason being, gravity takes blood where it needs to go, and they have relief of their discomfort. And it's repeatable again. If they start up and start walking again, they get the pain again. Then we go to the physical exam. If we don't feel adequately good pulses, that's another sign that there may be arterial blockage. So, and of course, we look at the patient themselves, their risk factor profile. If they're, age greater than 50, if they have diabetes, smoking, high cholesterol, a family history of atherosclerosis, then certainly they're at higher risk of developing these things, and we are, more vigilant. We look at all the arteries. We listen carefully for their carotids to make sure there's no turbulence, which may signify cholesterol buildup there. Listen to maybe sometimes their femoral veins, their femoral arteries here, make sure there's no turbulence there. So there's a lot of different things we can do even before we get to testing, just to kind of, raise our suspicion level and kind of, have a good, what we call a pre-test probability of disease.
Absolutely, you nailed it right there. And Craig Walker, who's one of our senior partners, always keeps on, there is no one simple physical exam finding that would give us so much information just looking at a person's legs or feeling their arteries, and if they have certainly ulcers, that's a big deal. And if they have diminished pulses for sure, and they have the right risk factor profile, it already tells you a tremendous story about this person's estimated cardiovascular risk. We may not be able to tell exact percentages, but we already know that this person is a significant risk for all these other aspects. And John, taking it to the next level, okay, we have this PAD patient, or we think the patient is a PAD by our physical examination and our history taking. What would the diagnostic trail be? How would you start? What are the least expensive to the more fancy diagnostic tests?
Sure. So, as I pointed out, one of the simplest tests is what we call an ABI, or ankle brachial index. And a very simple test that uses blood pressure cuffs, which anybody that's been to the doctor knows what that's about. But in this case, the blood pressure cuffs are put on the upper arms and then the lower legs. And we can measure the pressure difference. And by measuring that, if there's a significant difference between the extremities, then we know that one leg, or maybe even both legs, are not getting the blood flow that's comparable to what the arms are getting. That's one simple test that you can do in the office, and it really, in our experience, takes just a matter of 5 to 10 minutes. If that's abnormal, you can do ultrasound, Dopplers. Again, not very invasive. You can apply just some jelly with the ultrasound probe. You can actually map out the flow of blood through the arteries. If there is still concern or question, you can either do an angiogram or you can do a CT angiogram. Again, trying to decide what the risks to the patient are how invasive we need to be, how suspicious we are. We decide which route to go. But a CT angiogram is not much more than an IV and an injection of contrast through that IV, and then doing a CT scan, and can give you a lot of information of the entire arterial tree. Likewise, if we have serious concern and you go to the cath lab and you get a sort of direct image with angiogram where we actually place a catheter in the artery and inject the contrast directly to see the blockage, that's very specific, and it does allow us even potentially to apply treatment if we need to.
Absolutely, and I think those are all, and we'll take this question and go back to discuss a little more about the advent of CTA and how it has kind of facilitated the care of especially the interventional aspects of peripheral vascular disease. And it looks like line one has Shirley from Opelousas. Shirley, go ahead, you're live.
Okay.
Go ahead, dear.
Dr. Barrino?
Yes.
I'm calling to ask about I have problems with my leg.
Mm-hmm.
And I've had it since the second week of July. I've gone to the doctor. I've had x-rays and MRI. But today was one of my best days. But I'm still concerned that I have a little swelling on the lower portion of my leg. And I'm wondering if that's an artery problem.
Okay. All right, Shirley, let's just kind of try and discuss about your question and try to make some sense out of that. And we're just kind of cutting you off here, but we'll talk about that issue here. So she had, again, classic patient, whether or not she has arthritis, we do not know, but it looks like they're leaning towards a back and an arthritis type of workup. She had an MRI and an X-ray. She continues to have leg pain and leg swelling. Classic patient subset that we see. It may well be arthritis for all we know, but certainly depending on what physician she's exposed to, the same algorithm of physical examination, checking for pulses. Is she a diabetic? Does she have blood pressure? Does she have high cholesterol? Is she overweight? Does she have any cardiac risk factors? Has she had stents? Or did she have a bypass surgery or something? These would be all the questions we would ask in our clinic. And of course, check her pulses and listen for all these bruits and noises in certain areas of the body. And if they're abnormal, we could probably go on to the walker down that aisle of just doing that ankle brachial pressures, which would be a simple 5-minute test, which is probably one of the least expensive, most effective diagnostic tests that we have known.
Sure.
That it just is very, very accurate in most instances, except that the arteries are very calcified, very hardened, like in the case of diabetics or some people with dialysis. For the most part, they yield a tremendous amount of information for the nature that it's just so non-invasive and it takes so few minutes to do it. And it gives, and I think certainly Shirley would benefit from seeing a person who has some vascular experience, being cardiologist or being,
Do you think her concern about the swelling, very often, we get complaints of certainly arthritic type pains, but does the swelling seem to strike a chord with you? It certainly, for me, it raises my concern a little bit more. Now, of course, there are different degrees of swelling. If you're talking about just a line from a sock, I don't worry so much about that, but if you're talking about so much swelling you can't get your shoe on, then that certainly raises concerns about blood flow and potential vascular issues.
Absolutely. Venous, certainly both the and venous issues come into play here, depending on the acuity of the problem, whether there is more swelling or redness and so on. And then one has to be concerned about clots, which are a total different thing, which form in the deep veins or superficial veins that can cause swelling, as well as similar features, but the arterial problems are more exertion related and more advanced cases.
Correct.
They can be, what we call dependent rubor or redness when you dangle your feet, and if you elevate your feet, they can turn pale. And of course, among more experienced clinical clinicians, be it PAs or vascular specialists like us or vascular surgeons, can easily diagnose. Even an intern, anybody can diagnose this. It doesn't require a big vascular degree to go and diagnose a patient with PAD. And of course, if they have loss of all their hair and and if they have ulcers, and if they have things that if they get hurt and they don't